University of Kansas. I want to thank the folks who have made this possible, specifically Tracy Hart from the Osteogenesis Imperfecta Foundation, in partnership with Charlene Waldron from the Rare Bone Disease Alliance. This would not have happened without them. For those of you who wonder what ECHO means, it means Extension for Community Healthcare Outcomes. And it is certainly our goal and dream that we will be able to help many people with rare diseases by expanding the knowledge base that is out there. I do have a few housekeeping points for you. First, would you please be so kind as to type in your name, institution, and email into the chat box so that we can take attendance. And this can be done at any time, but please be sure you do it. Please be sure to keep your microphones muted. We're already very thrilled by the attendance, but to be sure that Dr. Rush can do his job, we'll need to keep the phones down to a dull roar. We are hoping for significant audience participation, and we would ask you to type your questions into the chat box, and we'll do our best to respond to as many as we possibly can. For those of you who want CME credit, and it is free, so please be sure you go for it, please be sure to fill out the survey link sent out earlier so that we can get this to you. Last but not least, today, Dr. Rush is going to be presenting his own cases. The tradition of ECHO is that the audience does submit cases. We are going to be smoothing this out over the next year as we evolve, but for the moment, if you have an interesting or troubling case, would you please be sure to reach out to either Michael or Rachel, whose number you have, so that we can forward those cases to some of the upcoming speakers. It will be important to receive any case you are worried about at least a month before the presentation that goes with it. So thank you very much for being here. And now it gives me huge pleasure to introduce Dr. Eric Rush.
Thank you very much, Laura. And Michael, I'm sharing my slides, so I hope everybody can see those. Michael, can everybody see my slides?
Let me see real quick. Can people give a thumbs up if they can see Dr. Rush's slides very quickly?
I can.
Thumbs up. Okay, I'm seeing some more thumbs up.
Okay.
Thank you, everyone.
Excellent. Thank you for letting me know. So thank you, Laura, for that kind introduction. I'm excited to be here to discuss genetic testing in the diagnosis of rare bone disease. I'm joined today by one of my colleagues, Susan Starling Hughes, who is a genetic counselor that also works with me on the rare bone disorders. So I want to start out by just acknowledging my disclosures for consultancy, research, and stock ownership, and then move on to a very brief discussion of what the Project ECHO is. So for many of us, this may not be our first ECHO project. We may have had other experience, but I suspect for many of you, this is your first time engaging in the Project ECHO. And so Project ECHO, or Extending Community Health Outcomes, is a project that involves sharing knowledge through video conferencing and emphasizes case-based as opposed to strict didactic learning, with the idea of building expertise and to deliver the best medical care, particularly in areas that are underserved. It has an interesting history that has really very little to do with rare bone disease in hepatitis C. So for those of you who may or may not be aware of the story, there was a pilot project that began quite some time ago to improve care of patients with chronic hepatitis C because they were all being routed to the same provider in New Mexico, and this created significant access issues. So in the original ECHO project, the ECHO platform was engaged, and a large number of patients who had chronic hepatitis C infection were able to be treated using this distributed echo model to build expertise, where these PCP learners for echo were achieving virologic responses that were similar to what was being achieved at the University of New Mexico Hepatitis Clinic. This proof of concept has really proven to be very important in the dissemination of information, particularly for rare diseases, and in some cases not so rare diseases, but maybe patients with just other sort of complex diseases, or in underserved communities. Keeping in mind that a significant percentage of my practice is in Kansas, those of you who don't know much about Kansas may at least know that it's a big state that doesn't have a whole lot of people in it, and all the people are shoved into one corner. And so building that sort of expertise in smaller communities around the state has been very good for patient care. And this has been replicated in many different places. Some things that are important to keep in mind is that ECHO is not a webinar. So ECHO is not just going to be me having my talking head telling you what to do. The idea is that there will be a short didactic at the beginning of each ECHO where a topic of import will be discussed. But ideally, what an ECHO is a way for us to share expertise and share information. And it's the ECHO works best when the participants are extremely active. And so in this case, although the case that's being provided is provided by Susan, and we kind of scripted this one for subsequent ECHOs, we want to make sure that that the participants feel comfortable and feel empowered to present their own cases, because that's really how we learn. And the other thing is that ECHO is not telemedicine. ECHO is a way for us to build expertise. And traditionally, this has been used with primary care teams, but it's not necessary that it has to be primary care. The idea is that an expert hub team will work with community-based teams, sometimes people who are also experts in regional clinics, and ultimately we all learn from each other, and so the patients have the benefit of the combined specialty knowledge and expertise. So much different than telemedicine. So now for something completely different. We're going to move from what is ECHO to the use of genetic testing. So genetic testing is a modality that I know that is more on the radar for all clinicians, not just geneticists. And so it's important for us to understand how we use that genetic testing. It's important for us to understand what sort of a tool this is. And so there are many different uses of genetic testing in medicine. There's diagnostic testing in a symptomatic person, predictive testing in an asymptomatic person, prenatal screening in a developing fetus, preconceptual screening for carrier status, and genomic screening, which is increasingly used for quote-unquote useful variation, although how useful it is a matter of some debate. What we're going to be discussing here is for the most part, diagnostic testing in a symptomatic person. There will be a little bit of discussion, or at least acknowledgement, of prenatal testing in a developing fetus. But for the rest of these, we'll table those for a different discussion. So how is this going to be helpful for us when we are doing genetic testing in skeletal dysplasias? Well, as it turns out, over half of the 436 described skeletal dysplasias have a molecular etiology, and I will say that I say over half as opposed to the specific number, because undoubtedly that number has changed since the last time an accounting has been made.
Dr. Rush, may I interrupt you very quickly? Could you put the slides onto the projection mode? Right now we see like your next slide and the notes section. That way people can see it bigger. So
how do we do that?
I believe it's going to be maybe display settings.
How's that?
Perfect. Thank you.
Okay. All right. Thank you, Michael.
No problem.
Okay. So, so again, this is a moving target because syndrome delineation occurs on a consistent basis, and we are very frequently finding new molecular identification, and we're finding new syndromes, and probably we will also acknowledge different skeletal dysplasias as we go along. So two key testing paradigms that I think bear some discussion. One is targeted testing, and the second is expanded testing, and I'll discuss a little bit more about what those mean. So when we talk about targeted testing, when we talk about targeted testing, we are talking essentially about a single locus, a single gene, or a very small number of genes that we're trying to evaluate. So this is the testing modality that we have traditionally in genetics. This technology has included Sanger sequencing, which is sort of our gold standard of sequencing, or the actually not so new now next generation sequencing. And in the past, we really did this out of necessity, particularly in the pre-next generation sequencing era. It was simply cost prohibitive to do Sanger sequencing on any more than one or a very small number of genes. And so at present, that's changed a little bit. With the decreased per gene cost of testing, one really should have a high level of confidence if targeted testing is utilized, because on a per gene basis, this is much more expensive than doing expanded testing, to the point where it is actually somewhat cavalier for a clinical geneticist or another provider to do a very targeted panel unless they have a fairly high level of confidence. I will say Susan often will give me a look if I say that I'm only going to test for 1 or 2 genes, because in most cases she's absolutely right and I should be doing more expanded testing. But some examples where that would be appropriate would include, for instance, analysis of exon 10 and FGFR3 to detect the known variant in a patient with a clinical diagnosis of achondroplasia. Or if you have a sequencing of RUNX2 that we know causes cladocranial dysostosis, if you have an infant with absent clavicles. I think any clinician could be excused for wanting to do targeted testing in that situation. So contrast this a little bit with expanded testing. So expanded testing involves a large number of genes, and typically when we're doing expanded testing, this large number of genes is unified by either a disease process or key phenotype features. So for instance, skeletal dysplasias is a perfectly reasonable disease process to unify a large number of diseases, or a specific type of skeletal dysplasia could be equally reasonable for us to be looking at for an expanded testing number of genes. And in all of these cases of expanded testing, we would choose to use next generation sequencing. Again, if we would decide to do Sanger sequencing for a large number of diseases, the cost would still be prohibitive and the turnaround time would be extensive. We can use expanded testing in an increased variety of cases. We don't have to be as knowledgeable about the diagnosis or as certain about the diagnosis, or in cases, even if we have a pretty good sense for what family a disorder will fall into, if there's significant locus heterogeneity, we are likely to want to use expanded testing simply because the yield would be poor if we did so in another way. This results in efficiencies of scale because this is less costly on a per gene basis. We oftentimes, if we're doing enough genes, we may get the per gene cost into the single digits, which is nice if you can do it. If we're looking at the top of expanded testing, kind of the most expanded that we would get in a clinical setting, we would be talking about whole exome sequencing. And whole exome sequencing is where we take all of the coding regions of each of the 20,000 approximately human genes, and we sequence those. And we are able to look for an expanded period or number of genes that we might be suspecting, or in some cases not suspecting. So it allows us to look for things that we may not be entirely intending on. Now, I will say that there are indications for which whole exome sequencing would be our go-to test as a first line. In skeletal dysplasias, I think that's less clear. In skeletal dysplasias, we find that expanded testing focusing on the skeletal dysplasia itself is often the desirable first test, and we may choose, if a patient has an unusual presentation or other compelling reason, we may choose to use whole exome sequencing as a second line. So as an example, if we're looking for where we would use an expanded panel, we may have a patient where we have a radiographic diagnosis of spondyloepimetaphyseal dysplasia. Well, that's a description of conditions that has significant locus heterogeneity, and so we would certainly want to expand our look in trying to evaluate a patient with such a diagnosis. But whole exome sequencing might be a better choice for a patient in whom we do suspect a skeletal dysplasia based on the radiographic findings, but we can't recognize a radiographic pattern to be able to put in a classification it might be at that point reasonable to proceed immediately with whole exome sequencing because you might get a better yield in that instance. So taking a little step away from the testing itself, I do want to acknowledge the importance of family history. We find in genetics that, that not all of our colleagues, not the ones on this call, but we find that not all of our colleagues do the best job on taking a family history. And as it turns out, that's one of our most potent tools in genetic medicine. So the first word I would say on family history is, please take one. That's really important. And it's important to do a more expanded family history than the what are there any diseases that run within your family. That's really not going to be sufficient for our purposes. I would say that was the family history I was taught as an internal medicine resident, but we can do a little bit better than that. It is important for both efficiency purposes and clarity purposes that the family history be targeted to the problem at hand, but still comprehensive enough that you can appreciate subtleties in that family history, which might turn out to be important to the underlying diagnosis, because not everybody wears their diagnosis on their sleeve. And I've included on the right here an illustration of the pedigree. And this is because the pedigree is the ideal format for family history, because it's an efficient way for us to record large amounts of family history information, and it's also an easy way for the viewer of the pedigree to be able to assimilate that information and to establish patterns such as the inheritance. So it is important. So one of the things I promised is that this would be a practical talk, that I wouldn't get lost in the weeds too much on this talk of genetic testing. So I want to spend some time talking about the logistics of this testing, particularly things like who's paying and how do you do it. So who's paying for the testing is often, strangely enough, the most important question that we have to ask up front. Because in some cases that's the patient, in some cases it's the third-party payer, the insurer, or in some cases it's a research grant. Now all of these are potentially viable, but it's important to know those things before testing occurs, because if you don't have the finances of the testing nailed down before the testing occurs, that is a good way to get some fairly unsettled patients or family members. And then where do you send the testing? There's a number of places that will do genetic testing for you. For those of you who work in large academic facilities, you may have a molecular laboratory within your own institution that does your genetic testing. If so, lucky you. That's a really helpful thing to have your own molecular laboratory. In some cases, some of our colleagues out in private practice may use large reference laboratories. The large reference laboratories that do biochemical testing will also do in some cases genetic testing as well. That genetic testing is often a bit more limited to that for those laboratories, and so they may only order the quote-unquote more common rare genetic conditions. And then last and probably most commonly utilized are commercial genetic testing companies. These are companies that are not reference labs in the way we typically understand them, but instead specialize in genetic testing itself. Typically, these are companies with a much more comprehensive offering, and so you'll typically be able to find something that you want. So what else is important with the logistics of testing? Well, sample is important. In the bad old days, a lot of times we had to use fibroblasts and take a skin biopsy to do testing. Fortunately, that's extremely uncommon now. And so I think for all intents and purposes, we would assume that blood will be the specimen needed for genetic testing. That's not universal, and in some cases it's acceptable to use a saliva sample, but oftentimes with a saliva sample, both the quantity and quality of the DNA is not nearly as good as one will obtain with a blood sample. So if somebody's asking me what sample would be preferred, generally speaking, I will say a blood sample, and that blood should be collected in the EDTA or purple top tube. So we prefer that it should be shipped overnight in collection, and if you do this, it's okay to ship at ambient temperature, but ambient temperature is not the same everywhere. Again, I would definitely not just assume that everything's going to be okay if you're shipping from Kansas City in August. Sometimes a cool pack's not a bad idea. So keep in mind that ambient temperature can vary and can be important. And the other thing that one should know is that you can store your blood if it's refrigerated for 7 days prior to shipping. So ideally, the sooner the better. But if you can't do it, i.e., if you're seeing your patient on the Friday and you can't get it out the door, then if you can refrigerate it over the weekend, that's probably going to be okay for you before you can get it shipped out the door. So what about turnaround time? It's different among the various labs, but there's some general trends. I often find that single genes or smaller panels can be 2 to 3 weeks, sometimes a little bit more depending. I find that the larger panels, it's more like 3 to 6 weeks. And for whole exome sequencing, probably more like 6 to 10 weeks. These are approximate values. Sometimes we get labs a little, or we get testing back a little quicker than we thought. Sometimes it takes quite a bit longer. But these are some general guidelines for turnaround time. And when people will ask what constitutes a smaller panel or a larger panel, and there really isn't an exact delineation what constitutes a small panel versus a large panel. And so, but I always say I call them as I see them. And so when I hear a 20 gene osteogenesis imperfecta panel, I call that a small panel. When I see a 180 gene comprehensive panel, that's a larger panel. So the bright line is somewhere in between, at least for me. And so once we get that testing back, so you've sent your testing out, you've picked your lab, you've gotten it off, and now you're going to get your test results back. So what are you going to get on that report? How are they going to present that information? Well, they're going to present it in terms of the variants that are found. So we don't like using terms like mutation because they're not really as descriptive as we would like. We use the term variant because the variant doesn't establish the actual function or the consequence of a finding, nor does it imply whether this is an inherited finding or this is something that is new in the patient that you're testing. And so we like to use the term variant, and we categorize into 5 categories of pathogenic, likely pathogenic, variant of uncertain significance, or you'll hear us say VUS or VUS, likely benign, and benign. And so this is an example of an abnormal report. And so in this case, this is the report in question identifies the specimen type, which was DNA derived from blood. It gives the purpose of testing and also what other samples were analyzed. In this case, there was a maternal sample that was provided, and it provides a result. And this result tells the state of the variant, which is heterozygous. It gives the predicted effects of the variant, which is pathogenic, and it describes the variant itself, which is a missense variant of the gene ALPL. It also says that there were no other variants identified. And so what this implies is the patient is heterozygous for a variant that could be causative of ALPL-related disease, which is hypophosphatasia. So again, this is what it looks like for a pathogenic variant. Now, variants of uncertain significance can be a lot more confusing. And so oftentimes when we do really expanded testing, we'll find a number of variants of uncertain significance. And I'm not going to belabor this point by going through all of these one by one, but when a variant of uncertain significance is identified, what labs will tend to do, or at least what labs should do, is they should provide some information as far as why they classified the variant this way. And this can help the clinician decide which variants are more concerning than others, because there are ways that we can approach variants of uncertain significance that will eventually result in them being promoted to a likely pathogenic or pathogenic state, or demoted to a benign or likely benign state. And so I'm including this more for your reference for the future, but this is the matrix that we use for the guidelines for interpretation of sequence variants. This was a 2015 consensus recommendation from the American College of Medical Genetics and the Association for Molecular Pathology. And so it gives some idea as far as how we decide which variants are categorized in each manner. And so again, I won't belabor this, but please, if you want to refer back to this by looking at my slides, you're more than welcome to do so. So interpretation of this can be a little bit challenging, and I find that clinicians that are not specifically trained in genetics will approach this in one of 2 or 3 ways. Some will assume that a VUS is benign, some will assume that a VUS is pathogenic, but I find that a lot of them just panic and give us a call. And giving us a call is fine. We certainly don't mind that, but we find that the approach to VUS varies significantly. And what we've also found for our classification of VUS is that it's really helpful to gain information on how an individual variant will assort within a family, especially if there are other people who are affected. If we find that a variant tracks very nicely with a family in which everybody's affected with the disease, it is in some cases possible to reclassify that variant. Additionally, if we're able to do so, if we understand more about that, how that variant behaves on a functional manner, oftentimes that's also a very powerful tool. And so both are possible to leverage for further interpretation of how we use variants. So I'm going to stop there. That is the didactic part of this presentation. Laura, are